everyone, welcome back to another episode of Med School Mondays with Promo. If this is your first time joining, I want to welcome you to the Psychiatry series. If you were here with us last week, thank you for returning. Today what we're going to talk about is elevated mood disorders. For those of you who checked out last week's videos, you'll notice we talked about depressive disorders, and then in the second video we talked about treatment for depressive disorders. And on Friday we actually did something really cool. We released our first Fun Film Friday video. That was a mouthful to say, but if you watched it, you get the point. So make sure you catch up on all those videos during your spare time. As I said, today we're going to be talking about elevated mood disorders. When you think of elevated mood disorders, what do you think? That's right, you think of bipolar 1 disorder, bipolar 2 disorder, you think of a cyclothymic disorder. So let's get right to it. So what I want to show you first is with elevated mood disorders, and this is going to help you also make a connection with depressive disorders. Think of it as you have a baseline mood. Now we all have a baseline mood, you know, like we're relaxed, we're happy, we're sad. We have a baseline mood almost on a day-to-day. Yes, things come in life. We sometimes we get very happy, sometimes we get sad. We usually bounce right back and we get to our baseline mood. Now consider this. Someone has a baseline mood. So this is the black line that you can see going across. Now, an elevated mood disorder means that their baseline mood has increased. That means you're going to see a spike in their mood. So we call this an elevation of mood. And a depressive mood means that instead of an increase, there's a decrease. So that's called a depressive mood. So if you can see the graph again, elevated, spike up, depressive, there's a downward sort of spiral. So when we think about bipolar disorder, you want to distinguish between bipolar 1 disorder as well as bipolar 2 disorder. What are we going to focus on? We're going to focus on the symptoms, the duration, and the treatment. So definitely let's start talking about the symptoms first. The symptoms of bipolar disorder. How are you going to remember all these? We've heard about distractibility. We heard about large, grandiose thoughts. There's a simple mnemonic. It's called dig fast. D stands for distractibility. I stands for impulsivity. G stands for grandiose behavior, grandiose thoughts. F stands for flight of ideas. So you're thinking, I'm going to wash my car, I'm going to paint the house, I'm going to build a picnic table outside. So just flight of ideas all over the place. Where are we at? A stands for goal-directed activity as well as psychomotor agitation. S stands for lack of sleep. So this person is not necessarily getting a lack of sleep, but they don't really need to sleep that much. So like 2, 3, 4 hours, they're up the next day just pumping, working out, running around, getting what they need to do because they have like a flight of ideas going on at the same time. And the letter T, talkative, very talkative, pressured speech. So make sure you remember that mnemonic, dig fast. Well, how are we going to make sense of that? So a manic episode, so in bipolar 1 disorder, you need a manic episode. Manic episode are just the symptoms we talk about. So there's going to be a bunch of symptoms. How many symptoms need to be present? At least 3 symptoms. So you need at least 3 symptoms from the dig fast for a manic episode to be present. And this needs to be affecting your functionality. That means you're putting yourself at risk. And what do you need to do? You most likely have to hospitalize this person. So think about it again. An elevation in mood, 3 out of these symptoms need to be present from dig fast. That's called a manic episode. Most likely that person is putting themselves into danger. You need to hospitalize this patient most likely, okay? How long do these symptoms have to be present for? 1 week. So the question stem, depending on what level of your boards you're at, it's going to say anywhere between 4, 5, 6, 7 days. It says 1 week, but even if it's less than that, if you think for a fact that this person is putting themselves at risk, it is bipolar 1 disorder as opposed to bipolar 2 disorder, okay? What else could be present? You could have psychotic features. Psychotic features may also be present while the manic episode is happening. So got to keep that in mind. What are the psychotic features again? We talked about some psychotic features last time, but we're going to talk about it properly when we talk about our disorders of psychosis. Some psychotic features could be hallucinations, delusions, illusions, and thoughts of disorganized behavior, disorganized thoughts, that kind of stuff, okay? So we said 1 week, at least 3 symptoms from the dig fast category. That is called a manic episode. Now in bipolar disorder, there's a misconception that because it's called bipolar, now you have to see the opposite. So that's not true. For you to diagnose your patient in a question stem that they have bipolar disorder, all you need is a manic episode present. They never have to have a depressive episode in the past. They never need to have a depressive episode coming forward in life. So it's always just a manic episode That's all it takes to diagnose somebody with bipolar 1 disorder on your question stem. Okay? You want to make sure you rule out some key medical things going on. Amphetamine use. Amphetamine use will also put someone at an elevated mood. So make sure you get a drug screen on this person. Hyperthyroidism. Hyperthyroidism can also lead to some of those symptoms we talked about. Irritability, distractibility, just anxious, jumping around, thinking about way too much at once. If you missed the topic on hyperthyroidism, we talked about that in our endocrine series. You'll see the links posted below. And then Pheochromocytoma, that's another condition where someone is having a lot of sweating. Again, we talked about in the endocrine issue, they're gonna have lots of high blood pressure. So that's all put in the endocrine series. Go review that if you have a chance to. Okay, so how are we going to now treat these people? We said, well, make sure you gotta check if the person is putting themselves at risk, putting themselves at danger, someone else at danger. You have to hospitalize the patient. Okay, so hospitalization. Again, you want to be very careful what kind of medications you use. Now, when I said all you need is an elevated mood to be, to diagnose someone with bipolar 1 disorder, someone may have a depressive episode. I'm saying it could be there. It doesn't need to be there for you to diagnose someone with bipolar 1 disorder. For bipolar 1, again, you're looking for the main symptoms, right? You got 3 out of the big fast symptoms. They're putting themselves at risk. That's enough to say this person had a manic episode, they have bipolar 1 disorder. The the depressive disorder could have happened, could not have happened, but we don't need that. But suppose a person came in, okay? This person comes in at this point in their life. This already happened in their life, like 5-6 years ago, they had a manic episode, it went undetected, but now they come into you because they have had a depressive episode. A doctor, a psychiatrist, maybe you forgot to ask some key questions. As a medical student, as a resident, you're taking exams, you forgot to ask some key questions. But you forgot to ask, hey, have you had a manic episode in the past? And of course, the patient doesn't think that that was necessary to tell you. So what happens, you may prescribe them some SSRIs, selective serotonin reuptake inhibitors, hoping to improve their mood. Now what happens, you offset the depressive episode and you can precipitate a manic episode. So you gotta be very, very careful. If you are gonna prescribe SSRIs with someone who has depression, make sure you rule out both bipolar 1 disorder as well as bipolar 2 disorder. You want to rule out both a manic episode that they've had one in the past or a hypomanic episode. Okay, so now let's focus on the treatments. It's a mood disorder, so of course we want to give them something that's called a mood stabilizer. We have a few different kinds of mood stabilizers. The first one is lithium. Now, do you guys remember lithium? We talked about lithium in our endocrine lectures. You're gonna wonder, why did we talk about it? Of course, it probably had to do something with the side effects. So watch this. Before we even get into the side effects, let's talk a little bit about lithium. What are the uses of lithium? Of course, BP over here stands for bipolar disorder. You're gonna use lithium for someone who has bipolar disorder to help stabilize their mood. What is the mechanism of action? This one you have to memorize, especially if you're taking your USMLE Board 1 exams, right? It inhibits the phosphoinositol cascade. Now you gotta memorize that. You gotta make sure that makes sense to you. It could be a question, they're talking about bipolar disorder. You're like, yeah, I know this. They're talking about, a mood stabilizer was given. You're like, yeah, I know this is gonna be lithium. And question might just be, what is the mechanism of action? So that's why you gotta make sure you're able to connect the dots. So that's inhibition of phosphoinositol cascade. Next, the side effects are very important. There's so many side effects of lithium, but we have figured out this nice little way that you can memorize it. Now, it's part of the alphabet, so that should be easy. L, M, N, O, P. Now, remember when we were kids and we had to remember the alphabet? L, M, N, O, P, Q, R, S, T, U, V. So that's exactly what it is. It's that first part of what I just said. L, M, N, O, P. The L stands for lithium, so you don't have to memorize much. L for lithium. M stands for movement disorders. What kind of movement disorders are we talking about? Tremors, okay? N stands for nephrogenic diabetes insipidus. Guys, this is the stuff we talked about back in the endocrine series, right? We talked about nephrogenic diabetes insipidus. It's when the kidneys are not retaining the water. So what happens to the osmolality levels of the serum? They increase. All the water is leaving the kidneys, it's going out, it's being flushed out. What is happening to the urine osmolality? It is decreased. So make sure, guys, you review that. And I will post a lecture in the description below so that you do not miss that. The letter O, you're thinking, what does the letter O stand for? Again, if you're with us with our endocrine series, the O stands for hypothyroidism. All right, I know that's a little bit of a trick. It's a stretch, but once you say it enough times, O stands for hypothyroidism, it'll make sense. And the letter P stands for pregnancy. So it is contraindicated if someone is pregnant. Why? Because if someone is taking lithium and the baby is born, it can cause this condition, a heart condition known as Epstein's anomaly. So we'll see that in the pediatrics section, but make sure you connect that. So LMNOP. Now important also is that these medications such as thiazides and NSAIDs, non-steroidal anti-inflammatory drugs, these will actually increase the intoxication of lithium. So that's important. Make sure you keep that in mind, okay? What did we say? We said, of course, if a female needs lithium, she's pregnant, what happens if they are pregnant? What can we do if they have bipolar disorder? Well, in the first trimester, you may recommend ECT, electroconvulsive therapy. Now, if you're with us last week, we said electroconvulsive therapy, there's no contraindications if someone is pregnant. Secondly, if the person shows up in the second or third trimester of their pregnancy, you can recommend a medication called Lamotrigine. All right, we'll get to that in a second. So Lamotrigine is also a safe alternative for female patients while they're pregnant in their second and third trimester. The next medication, Valproic Acid. So I want to draw your attention before we even move any further. Valproic Acid, Carbamezapine, Lamotrigine, these all have a very similar mechanism of action. They block the sodium channels. So all three have that in common. They block sodium channels. So keep that in mind. Specifically, Valproic Acid is used to help treat a lot of the different types of seizures. It's used to treat bipolar disorder, and it's also used as a prophylaxis for migraines. Okay? We said that one of their mechanism of action is increases the sodium channel inactivation. So basically it's blocking the sodium channels. Okay? Second thing, it's inhibiting this enzyme called GABA transaminase. What happens? The concentration of GABA increases. So this medication, Valproic Acid, has two mechanisms of action. So make sure you know both of them. What are some side effects? It affects the liver, it affects the pancreas, and it can also cause neural tube defects. So of course, it's going to be contraindicated in pregnant females. It's going to cause pancreatitis, like we said. It's going to be hepatotoxic. So make sure that if someone is taking Valproic Acid, you order LFTs, liver function tests, on a regular basis. Okay? The third medication, you've heard of this maybe in your neurology section, but if you haven't, that's okay. We're introducing it right now, and we'll see it again in neurology. It's called Carbamezapine. We already know what the mechanism of action is because we said Valproic Acid, Carbamezapine, Lamotrigine. These are all medications that block sodium channels. Okay? And the uses of it, bipolar disorder like we're discussing, as well as it's going to help with a condition called trigeminal neuralgia. Again, something we're going to talk about properly in the neurology section. This one has a lot of different side effects. I'm going to say them out. I know it might be a little hard for you to read, but I will make sure it's all printed like you'll see right now. Okay, so on the eyes, it's going to cause double vision, so diplopia. It's going to cause balance issues known as ataxia. It's going to cause some blood issues, aplastic anemia, as well as agranulocytosis. Next, again, liver stuff. It's going to be hepatotoxic. You're going to get LFTs. Skin, Stevens-Johnson syndrome. That's a big one. We're going to save it for our derm lectures, but it's Stevens-Johnson syndrome. It's going to cause SIADH, syndrome of inappropriate ADH, antidiuretic hormone secretion. Again, go back to the endocrine series. We have you covered on the SIADH stuff. Okay? For babies, it's teratogenic. It can cause a cleft lip and cleft palate. And also this one over here, what it says, increases the cytochrome P450 enzyme complex. And the last one here is acute dystonia. So what happens in acute dystonia? Someone's developing stiffness, muscle spasms. Another thing, it can lead to oculogyric crisis. Okay, and then that can also lead to laryngospasms of the throat. So someone may need intubation. So it is a serious side effect. Okay? After discussing carbamazepine, we now go into lamotrigine. Lamotrigine, we already know the mechanism of action, guys. It's the blocks the sodium voltage channel, just like valproic acid, just like carbamazepine. And we have this big one again, Stevens-Johnson syndrome, that we're going to discuss in our derm lectures. The last one is antipsychotics. We're going to say that again for our psychotic lectures, but we're going to see why antipsychotics can also be used. As we said, remember, if it's bipolar 1 disorder, they may have psychotic features. They don't have to have psychotic features, but if they do, antipsychotics will play a big, important role in that. What if now we're trying to distinguish whether it's bipolar 1 disorder or bipolar 2 disorder? How do we do that? So recall, bipolar 1 disorder, we said we have a manic episode that lasts approximately a week. 3 symptoms need to be present, and someone is putting themselves at risk or someone else at risk, so we got to hospitalize the patient. We said psychotic features may or may not be present. When we compare that to bipolar 2 disorder, we say the person must have a hypomanic episode and a depressive episode. So they can't just have a hypomanic episode, they can't just have a depressive episode, they have to have both, okay? How long does the hypomanic episode need to last for? A minimum 4 days. There's going to be no psychotic features present, and the person is not putting themselves at so much risk or someone else at risk that they need to be hospitalized. So how do we distinguish that? Hypomanic, you want to think like, if we're comparing it to this graph over here, their mood elevates, but not as high. This is danger zone. They're elevating like maybe there, around there. So it's going from hypomanic episodes, then they're going for some time when their mood is completely back to baseline, and then some depressive episode. It could be another depressive episode, another hypomanic episode, but it doesn't reach a manic episode. Again, you got to be careful during the depressive phase. You don't give SSRIs because that could flip things out and precipitate a manic episode or at least a hypomanic episode. Okay? Now, depressive symptoms, of course, we talked about that last week as well. In case you forgot, you need to remember this mnemonic called SIADH. We put out a video back on Monday, last week Monday. We also put a fun film Friday for you guys on Friday. So we go over what SIADH means. Okay, so that's how you keep the difference. Again, remember, you're not gonna have to hospitalize someone who has bipolar 2 disorder. Okay, and then what is the treatment? You can use any of these things again. Basically, you're gonna focus on your mood stabilizers. You're not gonna need to go for the antipsychotics because the person doesn't have any psychotic features. Last one over here is cyclothymic disorder. Cyclothymic disorder needs to be present for approximately 2 years. Most of those 2 years, the person is going to experience symptoms. There's going to be remission, but remission cannot be any more than 2 months. So you would say remission 2 months or less. What exactly is it? It's a mild depressive symptoms, then hypomanic symptoms, and it fluctuates. Okay, so again, it's some time where it goes down like this, up like that, maybe another one up, maybe another one down. So it's a fluctuation of depressive symptoms, mild depressive symptoms, and then hypomanic symptoms. Again, when we say hypomanic symptoms, we're referring to our dig fast, but not at such extreme levels, not at the extreme danger levels that the person needs to be hospitalized, okay? And that's it. Again, you're gonna treat these patients with mood stabilizers, and of course, there's always therapy as well that you can offer your patients. And that's it, everyone. We just had a nice discussion on elevated mood disorders. That was high yield, concrete, right to the point. So in case this is your first time here, make sure you hit the subscribe button, make sure you share the video with your friends, and definitely leave a comment. Let me know what you want to learn about because we're going to be making a lot of new lectures in the next couple of weeks. For those of you returning users, I want to thank you guys for coming back. I will see you guys again on Monday. And have a great week. We'll see all of you on Med School Mondays with Promo.